Hello and welcome to the first in a series of videos about performing QA on a linear accelerator. The first video in this series is going to be an introduction to performing TG142 monthly QA. We're going to look today at performing these tests on a TrueBeam linear accelerator. For those of you that are not students or graduates of the graduate program at Toledo, welcome. My name is Dr. David Pearson. I am the Residency Program Director and Clinical Physicist at the University of Toledo's Medical Center, Dana Cancer Center. So to get into the purpose of this video today, essentially we're in COVID-19 lockdown and we cannot teach the labs that we would normally teach during the summer. And so we're trying to provide videos so that students and residents can use this as a future reference, and it will not really be a replacement for actually doing in-person training, but it could be used as a prerequisite for the in-person training, or as an additional resource on top of that training. So the first thing we're going to do, as I mentioned, is talk about TG142 testing on a linear accelerator. We're going to start off with a TrueBeam, and then we will discuss any additional tests that would need to be done on a stereotactic linear accelerator, which our TrueBeam is not. I'm going to break down TG142 requirements into a series of categories, and we're going to actually do those tests and record myself or one of our residents doing the tests. And we'll break it down into blocks. So the first block will be dosimetry. We'll talk about how we would perform output testing for photons and electrons on the linear accelerator, and all of the tests that would fall into that category. So let's start off with that. So TG142 says that we should test the output of our linear accelerator on a daily and a monthly basis. So we're going to cover the monthly part of that today. We're going to be talking about the tests that are going to be performed by a physicist on a monthly basis. There'll be another video in the future about how to do this, the daily, which is usually performed by the therapists in the morning, but all physicists should know how those tests work, and how to analyze the data, record the data, and what the results mean. But for the monthly, let's talk about the dosimetry test. So output of a linear accelerator, according to TG142, for a machine like ours should be within 2%. And to measure that, we're going to place plastic slabs on the table with an ion chamber under specific conditions, and deliver a beam of known monitor units to the plastic, get a recording of a reading. And what we want to see here is that it doesn't fluctuate within 2% from our baseline. So for monthly, it is not necessary to calculate the output of your machine in units of centigrade. It is only necessary to prove that it is consistent. And so what we're going to be doing is consistency testing. So it can be confusing because we're going to be measuring the output of our machine, and we're going to be stating it, the output, in centigrade, and we're going to be stating any deviations in that way. However, the actual test itself is not really calibrated. The output is not calibrated, so the real units of the output from our monthly test are not centigrade. But of course, we need a unit to be able to compare from one to the other. And so it just makes sense that we kind of call the output centigrade when in actual fact that's not really what we're measuring. If we were doing TG51 under these circumstances, then that would be true, but in this case we're just measuring with plastic. We are not using the TG51 calibration factor for an ion chamber. The ion chamber that we're going to be using for this test does not have to be TG51 calibrated. It just so turns out that for the test that we do today, it will be a TG51 calibrated chamber, but at no time during the monthly will we actually use the NDW cobalt-60 calibration factor that we get from an ADCL. So output should be within 2%. We're going to measure that in plastic. I'm actually going to show you a couple of different ways of doing it. We've moved from using plastic slabs to a cube phantom. The advantage of the cube phantom is that you can set it up, and then when you need to measure at different depths, you can just rotate the cube and move the ion chamber to a different point within the cube. So it's kind of nice, kind of handy. We've just recently purchased one of those cubes, and previously we did this all with plastic slabs. So every time you wanted to measure at a different depth, you had to change the plastic slabs, rearrange them, maybe change the SSD, although that actually turns out not to really be necessary. But it really does depend on how you've got it all calibrated. So our system, we have an old system and a new system. I'm gonna try and show you both, and then we'll look at the output both ways. Next test is the output check for electrons. So the TrueBeam does have the ability to produce beams of electrons for superficial treatment. We will be covering the output of that also. Again, that's going to be used in plastic slabs, and again, the output for that test is 2%. At the same time that we're doing those measurements, we're also going to be testing the accuracy of our backup monitor chamber. So in the linear accelerator, there is actually 2 ion chambers stacked one on top of the other in a single unit. And that ion chamber measures both the output of the machine. It has a secondary chamber which measures the backup. The output of those is called output 1 and output 2, or MU1 and MU2. So it's actually measuring the output using 2 different independent ion chambers mounted sequentially. And it's important that both of those are working. So either of the monitor chambers, the monitor ion chambers, should be able to shut off the beam. And so to test that that is the case, we will be having the beam stop when it gets to 100 monitor units according to ion chamber 1, the primary, but then recording what ion chamber 2 says. So ion chamber 2, if we shoot 100 monitor units, ion chamber 2 should be within 2% of ion chamber 1. In other words, 98 monitor units to 102 monitor units. As it turns out, that we're always way more accurate than that, and I would suggest that if it's half a monitor unit off, you speak to someone about it, maybe get a service engineer to look at it, and you may be able to fix that by recalibrating your ion chambers using TG51 protocols. So next up, we've measured the output. We've recorded MU1 and MU2 to make sure that MU2 is consistent with MU1. That's called the backup monitor chamber constancy test. We're also going to look at different dose rates. So our machines have to be able to operate at many different dose rates. For example, we have a 10 FFF beam with the highest dose rate is 2400 MUs per minute. And it could be used for IMRT, where it could be delivering only a few MU per minute. So we actually test the output of the machine over a number of different dose rates, just to make sure that if I shoot a beam of 100 monitor units at 200 monitor units per minute, and then I shoot a same beam with 2400 monitor units per minute, I actually end up with the same measurement, therefore meaning that the output of the machine is constant, regardless of dose rate. And that's important, especially when you're doing IMRT or VMAT, which is what we use a lot. Beam profile constancy. So this is another test. Essentially, this is to make sure that your beam is, well, I don't want to say flat and symmetric. It should be symmetric, but it does not need to be flat. If you're using a FFF beam, the beam profile does not have to be flat, but it does have to be consistent. So if you're using a FFF beam and the beam profile looks like this over, scanning at 10 centimeters in water, and you measure a peak for a profile, you should measure exactly the same peak every day, every month, every year. So constancy of the output of the profile is important, and that needs to be measured on a monthly basis with a constancy of 1% for our machine. So how do we do that? Well, there's a few ways you can do it. I would recommend using a beam profiler if you have one. This is a device that has ion chambers or diodes in a linear array, and you can shoot a wide field onto it. You can obtain a profile, and you can do that from month to month and just do a subtraction of one profile from the other and measure all along the profile, verifying that it's all within 1%. If you don't have that, you could use a daily tracker, and that's actually the way that we're going to show you in these videos. I think it could also be done with an EPID, so you can measure a beam profile with an EPID, quantify the flatness and symmetry, and then measure it again in the future and make sure you get the same flatness and symmetry. Or you could get a profile and then again do a subtraction. You can use something like a map check. So a map check is a device used for doing IMRT-QA, which is a 2D array of diodes. So similar to the linear array of diodes for a profiler, this is a 2D array. Tend to be a little bit smaller, can't do as big of a large profile, but also have the ability to measure in-plane and cross-plane profiles simultaneously without having to rotate the phantom. And this can, you could actually measure a baseline in the software, make a baseline, and then every month use the map check to measure the beam profile again, and then do a point-by-point subtraction and make sure that there's nowhere along the profile that's varying within 1%. So that's an alternative way of doing it. Again, we don't do it that way, but you could. I think we have done that when our tracker, our daily tracker, has been sent out for calibration or for repairs. So we needed to come up with an alternative. And again, we don't have a 1D profiler. We don't have any software for acquiring images on our EPID and doing a subtraction, or at least nothing particularly easy that could be implemented into the QA very easily. But all those ways are possible, but the way we're going to show you today is going to be doing it with a daily tracker, which is probably the crudest, probably the least accurate way of doing it, but it is, again, we're only looking for consistency here. It's only going to give us, a tracker is only going to give us 2 points on a profile, or 3 points if you include the center. So there's going to be a point in the measurement, there's a point in the center that's going to get a measurement, and then there is an ion chamber, I think it's 5 centimeters to the left and 5 centimeters to the right, 5 centimeters in and out, and so you can get profiles in both directions automatically and compare those from month to month. So I said that's how we do it. Very easy, very reproducible, conceptually easy to understand, and does give you good results. So that is what we use for a daily. When it comes time for doing, and the monthly, but more importantly the monthly, that's what we're talking about today. But you can also do tests on an annual basis, and for that you probably want to do something. I would highly recommend doing something more in depth and using a daily tracker to measure your beam profile. We would, for example, use a 3D water phantom. That is going to be a different video. So getting back to dosimetry testing, we've talked about output, we've talked about the backup constancy for the backup chamber, using typical dose rates to make sure that's consistent. We've talked about beam profiles. By the way, one of the reasons we don't use the map check all the time, even though it theoretically is a better device for measuring constancy of the profile, it's also very simple to use, is that it can be a bit problematic when it comes to electrons. You would be shooting a beam 25, maybe a 20 or 25 or 25 plane of electrons onto the diodes of a map check. You might have concerns about radiation damage to the diodes from the electrons, and so therefore you might not want to do that. The map check was not designed for electrons. It was designed for measuring photon beams, for doing IMRT-QA, so really wasn't intended for this purpose, and might violate any warranty that you have by shooting beams of electrons onto it on a day-to-day basis or even month-to-month basis. So that's why we use the tracker. That's another reason we use the tracker. It is intended for photons and electrons, but we have to measure profiles of our electron beams, and that has to be within 1% also. And then, interestingly, TG142 says that we should measure the electron beam energy constancy on a monthly basis. Does not mention that we should measure the photon beam energy. So I'm not going into details of why that is, but I will tell you that at Toledo we measure both photons and electrons we're going to measure the output of all of our beams, because if you're going to do it for electrons, why don't you do it for photons, especially on a machine where you use photons. You know, every 9 out of 10 patients, if not more, is going to be a photon treatment. So why would you choose not to measure the energy on a monthly basis? So we do that. There's a number of ways we could do that. You could get that data, I suppose, from a daily tracker. Again, probably not recommended. We want the energy to be constant within 2%. TG142 says the electron should be within 2%. We're going to assume that it would be very reasonable to say that the photons would also be reasonably within 2%. If it was required, which it isn't. So we're basically going to make up our own test here and say that it should be within 2%, and that's fine. So we do a few tests that are above and beyond what's in TG142, and that's one of them. And so how do we do that? Well, energy, it's not really quantifiable. We don't have a spectrometer. We cannot say what the energy of our machine is. And again, this is the monthly. We actually don't really care. What we want to make sure is that at the time that we accepted the machine and to now, it is the same. So if we have a 6MV beam, if Varian called it 6MV and we accepted it as a 6MV beam based on the dose at 10 centimeters, 5 centimeters, Dmax, all those ratios, we want to make sure it's the same now. And so how do we do that? Well, you only need to measure a ratio between 2 points. So if you put an ion chamber at one depth and then at a deeper depth, and you took the ratio of those two, if the energy hasn't changed, and that's the important thing, we don't care what the energy is, we just want to make sure it hasn't changed. If the energy hasn't changed, then the ratio between those two measurements should be the same. So for example, if you measured at Dmax 100 monitor units, and then at this at the same setup you measured another beam at, let's say, 10 centimeters, for a 6MV beam you would expect that ratio to be about 68%. If you measured that ratio, the ratio between those numbers after being, I guess it doesn't even need to be corrected for temperature and pressure, as long as they were at the same temperature and pressure for both measurements, which they would be if you did them in the same day, you would get the same ratio. So that's what we do. However, we don't measure necessarily at exactly Dmax, and we don't measure the deeper one to be at 10. The actual numbers, the actual ratio of depths that you use is not important. You probably shouldn't use Dmax and 2 centimeters or 9 centimeters and 10 centimeters. You should try to keep the two numbers to be different from each other. So we would measure at something close to Dmax and about as deep as we can reasonably measure with plastic. So when we did this with the plastic slabs, we would measure at Dmax approximately, not exactly Dmax, and then we would measure again at, I think, about 8 centimeters. We would put a slab on top of the slab with the ion chamber hole drilled into it, and take a ratio of those two measurements, and I think the difference between them was about 8 centimeters. So that would be the ratio that we'd be looking at. But again, it doesn't really matter. Since we've transitioned to the cube, the difference between those two readings, I think, is 5 centimeters, although we'll verify that when we do the measurement. And that gives us our energy number. Again, we're going to do that for photons, we're going to do it for electrons. A ratio at 2 different depths. Obviously, if you're going to use Dmax and 10 for photons, that's not going to work so well for electrons. 6MV beam at 10 centimeters is nothing. You're not going to get any measurement, except for some photon contamination. So you have to, we like to obviously make our lives as easy as possible and make sure that we're not doing going in and out of the room, changing the depth of the ion chamber when it's not necessary. So we've tried to come up with a system that doesn't require us to keep going in and out of the room, changing the depth of the ion chamber much. And so when we actually do this measurement on the machine, I'll show you the depths that we're going to use, and I'm going to show you the spreadsheet that we're going to use. So that's the energy of our photons and electrons. Finally, to finish off the dosimetric parameters, in this section, we're going to measure the output of a beam that has a wedge in it. We'll go into wedges in more detail in a future video, but at this point, it's just important to say that the output with a wedge should also be within 2%. So you're measuring the output with a wedge in the beam. And excuse me, you're going to do that and verify that it's your output is within 2%. And so that would conclude the first section. That is the outputs, or what we would call output and energies, but essentially all of the dosimetric properties. There's going to be some other measurements that also require dosimetry measurements, such as gating, but we actually put those in a separate section, even though they might be measured at the same time. The next section in TG142 is going to be the mechanical testing of the machine. So any moving part on the machine well, actually not quite every moving part on the machine. There's some things like carousel and stuff like that you don't necessarily directly measure the motion. But some of the bigger components, table motions, gantry motions, collimator motions, jaw motions, things that have a very direct effect on the patient's treatment, those are all going to be measured for accuracy. So first test that we're going to do in the mechanical section is going to be the light and radiation field coincidence. Now, on a modern linear accelerator, or any that I have ever seen, there is a light field. The light field projects a light onto the patient to tell us where the radiation is going to go. Pretty simple. It's days track back to very simple 3D treatments where you just treated a patient with an open field, or maybe a field with a cerebend block, and you wanted to see where that radiation field actually hit the patient. Very basic and just a very simple way of doing QA, a very appropriate way of making sure you're hitting the patient in the right spot. For example, let's say you're treating the left breast of a patient with tangents. You would want to make sure that the light field hits the sternum, is treating the left breast, and is not spreading over into the right breast if it wasn't intended to, if it wasn't planned that way. So we could use the light field in that case to check to make sure all of the breast is within the treatment field and the other breast is not in the treatment field, and the edge of the treatment field is exactly where we intend it to be. That is very simple QA. And even with all the modern QA that we do today, tests such as that are still important. So we still use the light field, not as much as we used to. It's not as critical as it once was. When it comes to IMRT and VMAT, probably never use the light field, because other than to maybe use the crosshairs, which I don't even think the therapists use that, set up using lasers and then do imaging. In any case where you've got intensity modulation, you might not be using the light field as much. But for 3D treatments, still important to use the light field. Anyway, the coincidence between where the light field shows the radiation going and where the radiation actually goes needs to be within 2 millimeters. We pretty much take that as being 1 millimeter on either side of the field. So that means you shoot a field of radiation and you measure the field size with the radiation, and then you compare that to where the light says the radiation should be. One way you can do that, for example, is to use a plastic slab with BBs. So let's say you're doing a 10 by 10 field. You would want a BB of 5 centimeters in each of the cardinal directions, in the middle of each jaw. And you would want to make sure that the light hits exactly that BB in the middle, and then you shoot the field with something underneath it, like a piece of film, or more often and more regularly an EPID. Shoot that, and you would expect to see the radiation also exactly halfway over the BB. So if the light field is exactly halfway over the BB, the radiation field is exactly halfway over the BB, and you do that for a couple of different field sizes, you can verify that your light field, you visualize the light field, you visualize the radiation field, and they're in coincidence. Let's stop for a second to talk about why it might not pass. The light in a lot of accelerators is projected into the field by a combination of a light bulb and which is out of the field, and a mirror to project it into the field. So for example, if you have a half silvered mirror and a light bulb off to one side, here's the beam of radiation, light bulb is over here, there's a half silvered mirror here, and the light hits the mirror and then projects down onto the patient through the jars. That is going to be in coincidence with the radiation because it's going through the jars, but if the mirror has tilted or the light bulb position has moved, then where it ends up on the patient might not be the same as where the radiation is, because the radiation is coming from the head down through the jars and the light is coming from the side bouncing off a mirror down. So if either of those are out of position, your light field could change. There's also been cases where the symmetry of the beam has been steered incorrectly, so that there's like more radiation beam pushing down to one side of the patient, and that can actually have a slight effect. It would be more likely to be picked up on our profile test because that's within 1%, but it could, if it's off, it could also affect your radiation light field a little bit. But chances are the main reasons this could be a problem is if your light projection system has a problem. Now, not all machines have that mirror. The TrueBeam, for example, doesn't use a mirror. Instead, it uses a light bulb in the carousel. And this is why you can't have the light field and the radiation on at the same time. So when the machine is set up to deliver radiation, you can't see the light field. And when it's set up to deliver a light field, you can't deliver radiation. And that's because the X-ray target or flattening filters are in a carousel, and the light bulb is also somewhere in that carousel. Not entirely sure of the exact geometry of this, but it's somewhere up at the top of the head, and it cannot shine down onto the patient and be in treatment mode. The advantage of that is that it eliminates the error that the mirror could cause. I've actually seen it where the mirror, after years of radiation going through this very, very thin plastic mylar sheet that was the half-silvered mirror, the mirror actually crumbled and disintegrated due to constant exposure to radiation, and it's, became harder and brittle, and then eventually one day it just collapsed. And then the mirror falls down and lands on the plastic sheet, which is the drum skin between the outside world of your accelerator and the inside world of your accelerator. And you look up into the light field and you don't see a light field, but what you do see is little pieces of shiny plastic sitting on your mylar screen, which we sometimes call the reticle. So if you don't have a light field and you see lots of little shiny pieces of plastic up there, that's why. That was definitely true on some of the older accelerators. Not really sure about modern lighters, but modern TrueBeams, digital TrueBeams, don't have a half-silvered mirror. So that's one less thing to worry about. However, you have a moving light bulb now. You have a light bulb on a carousel. So you remove one potential problem and replace it with another one. So we have to measure the light field and radiation coincidence. We've talked about that. We also have to do this for asymmetric jars and symmetric jars. So essentially that means that's two different, it's in TG142 as two different tests, but we're going to do it as one test. We just have to make sure that instead of doing a tolerance of 2 millimeters, we say it's 1 millimeter per field size, and that covers us for both of those. The next mechanical test in our list is going to be the distance checker. So this would mean testing the lasers against the front pointer, or in addition to that, the optical distance indicator against the front pointer. So the front pointer is always going to be our gold standard. The front pointer is a measuring stick that attaches to the head of the machine and can be used to set a point that is exactly at 100 SSD. And it's hardly ever used by therapists, but it is our gold standard. So we use that to verify that to set that as our baseline of what is 100 centimeters from the source, or what is 90 centimeters from the source. What the therapist uses is lasers and also an optical distance indicator. An optical distance indicator is a light that shines down from the head of the machine and projects a ruler onto the patient's skin, which allows the therapist to determine how far away the skin of the patient is from the source. Again, there can be problems with that due to the light projector system not projecting it accurately onto the patient. If there is any knock inside the head of the accelerator, the projector system can be knocked out of alignment, and then it doesn't match up with the gold standard, which is the front pointer. So we checked that. Again, we have seen that be a problem. We had some major mechanical overhaul done to the head of our machine, and when everything was done, we accepted the machine back into service. One of the things that we hadn't immediately thought of checking was the optical distance indicator. We'd done many checks to make sure everything was good, but we didn't actually think about checking the optical distance indicator, and then we found out that the therapist was using that on a daily basis to set up the cube that they use to verify imaging ISO center, and it was failing. And the reason it was failing was because the ODI was off by about 1.5 millimeters, where the tolerance for that test is 1 millimeter, and so it was actually having a knock-on effect and causing other things. Now, the therapist actually should have found that problem in a different way. They're supposed to actually check the ODI against the front pointer, but I'm pretty sure that if you took the front pointer and hid it from the therapist, they would never notice. It is listed on our monthly QA that they should check that, but I don't think they do, and I should probably talk to them about that. Anyway, so we need to check the optical distance indicator, and we can also check the lasers at the same time, or at least a very simple test of the lasers. We're going to check the gantry and collimator angle incidence. So, gantry and collimator angle indicators. This means rotating the gantry with a bubble level to different cardinal gantry angles and verifying that when it's at 0, the bubble level says it's at 0. When the gantry is at 90, the bubble level says it's at 90, doing that all the way around for the 4 cardinal gantry angles. We then repeat that test with a collimator. You can rotate the gantry to 90 degrees, and then you have the collimator rotating like this in front of you, and again you can align straight edge with a bubble level and measure it at 0 and 90 and 270 and verify with a bubble level that your collimator angles are correct. So you set the angle using the bubble level. That's the gold standard. Then you read it off using whatever the machine indicates, and then the difference between those two is the error in that. Tolerance for that test for both gantry and collimator is 1 degree on our machine. However, you should never see it be off by a few tenths of a percent. So realistically, you're going to see big problems. You have bigger problems if it's even close to that tolerance. But the actual TG142 test says it needs to be within 1%. Next test is accessory trays. If you have any accessory trays, when you position them in the machine, they should be within 2 millimeters. We have no accessory trays. We have no externally mounted blocks other than the electron cones. Those are tested separately, so no accessory trays. We don't worry about that, but it is listed in TG142. Jaw position testing. So the jaws need to be accurate both symmetric and asymmetrically. Since we test asymmetrically, it's not really necessary to test them as well symmetrically. So the asymmetric jaw test involves setting up a field such as 10 by 10, moving one jaw in, making sure it goes where it's supposed to, moving the other jaw in, making sure it goes where it's supposed to, and then repeating that for the other 2 jaws. So you're testing all 4 jaws, making sure that each individual jaw can go to a position within 1 millimeter. Every jaw has to be able to move within 1 millimeter. So you send it to 0, you expect it to go to 0. When you send it back to 5, you expect it to go to 5. So that's how we do that. We actually shoot that onto an EPID, and we can analyze the image and verify that all of our jaws are actually going where they're supposed to. So that's how we do that test. We mentioned earlier that the plastic screen between the outside of the machine and the inside of the machine. So when you look up inside the head of the machine, you see a plastic sheet with a cross on it. We call that the reticle. That black cross should indicate the ISO center of the machine when it's projected down onto the patient, and it should be centered within the collimator. If it's not centered within the collimator, then when the collimator rotates, that cross will actually walk out in a circle. So what you measure here is to verify that that crosshair is centered properly is called the walkout test. You rotate the collimator and you verify that the crosshairs don't walk out. If the crosshair stays in the center of the field and never deviates more than 1 millimeter from that center, then your reticle crosshair center is centered properly. We have seen that be a problem. We know that it can be a problem. I guess I don't really think I've seen it. But whenever there's a messy incident on your machine, you might end up with getting something, some sort of bodily fluid onto the reticle if the machine happens to be at 180. And then that mylar screen gets damaged, maybe needs to be replaced, and then it has to be centered properly by one of your service people. And of course, it's up to us to verify that they have done a good job. If you have physical wedges on your machine, you have to make sure that they are positioned into the machine accurately. We don't do this test because we don't have any physical wedges. We use only enhanced dynamic wedges, or EDWs. So we don't need to do that test. Next test is the compensator placement accuracy. This is similar to the accessory tray, and again, it would be a tolerance of 1%, but we don't have any compensators mounted to our machine. If you have physical wedges, when you place a wedge into the machine needs to recognize it correctly as being the correct wedge. Again, we don't have that, so we don't need to do that test. And then finally, the last test we do for the mechanicals is lasers, checking to make sure that the lasers actually are incident exactly on the ISO center of the machine within 1 millimeter. Now, there are a lot of lasers on our machine. The main ones that we're interested in are the ones mounted to the walls of the machine, and those are the ones that we're actually going to test. There are actually lasers mounted to the machine itself that project up from the where the EPID panel is mounted. On a lot of machines, you'll see those covered with tape so that they can't be used in the clinic. And one reason for doing this is so that if there's a problem with them, you don't have to fix it. They're not necessary if you've got gantry lasers. If you've got wall-mounted lasers. So the therapists are not using them. So you can cover them up or disable them in some way. Easiest thing to do is just cover the aperture with tape, and that solves that problem. So we've done that. But the wall-mounted lasers, you have one on the left wall, one on the right wall, one above the patient, which you can only see if the gantry is not at 0, and then one mounted to the far wall at the foot of the table, which would project down onto the patient, so that even if the gantry is at 0, by the way, gantry 0 is up for us. That's not universal. Sometimes 180 can be up above the patient's head. So if the patient is looking up, that could be 180 on your machine, but for us it's 0. So anyway, the gantry on the wall above the gantry, the laser on the wall above the machine should match the one projecting down the length of the table. And so that when the gantry is not there, you see a perfectly centered line, and then when the gantry moves out of the way, you see another line projected exactly on top of that. And that gives you in and out position of the ISO center. The wall-mounted lasers give you, wait a minute, sorry, what did I say? That's say in and out. It gives you basically a left to right. So that laser above the patient projects and allows you to position the patient left to right. The lasers mounted to the walls have a vertical laser, which allows you to measure in and out motion of the patient. And you have a horizontal laser, which allows you to position the up and down. If the patient's lying prone or supine, then it would be the anterior posterior motion of the patient is measured by those lasers. All of those lasers should project to a single point, which is the ISO center, and the accuracy is that all of those lasers need to project to 1 millimeter. You'll notice that one of the tests isn't to verify that the lasers aren't rotated, and that is actually something that can happen. The lasers can rotate, so they might be projecting onto the ISO center but not be actually horizontal and vertical. So you should check that. TG142 doesn't say that has to be accurate, but you do want it to be accurate, because the therapists don't necessarily only use the center. When they're given a projecting line, they're going to use the line and not just the point. So it needs to be accurate everywhere. But that is essentially something that you can kind of eyeball and make sure that it is reasonable. And again, you would want to make sure that on one side versus the other side, it's correct. Physics is actually going to use these lasers to set up devices like the arc check and phantoms, and they're going to want to make sure that the phantom is not rotated. So we definitely need that. We will fix that if we see a problem with the lasers. So we've covered the dosimetry, and we've covered the mechanical sections. I'm going to take a break for a second, and we're going to come back, and then we'll talk about safety tests, respiratory gating tests, EDW tests, MLCs, all of the imaging on our machine, what needs to be tested there. And then we've already talked about the last thing, which is additional tests that are not required by TG 142, and that for us is energy check for the photons. But we'll go over those additional sections in a second. So I will see you in a minute.